Hi everybody, my name is Caroline Stirling. I'm a palliative care consultant and worked for a long time up on the paediatric teenage palliative care, teenage oncology unit at UCLH. So Abby's asked to talk to you about sort of palliative care in oncology. I'm going to talk to you initially about sort of numbers of patients with cancer in the world scale of things and the different age group, the sort of model of integration of palliative care within oncology, talk to you about sort of keys, what I find keys to communication with a child with a life-threatening illness, which could be cancer, doesn't necessarily need to be, and other things outlined on the slides. So many of the next slides should be familiar to you. Abby, if you can just move the slide on, sorry. Are you there? Or am I able to do it, Abby? Yeah. So this slide shows you the sort of where the numbers of people with cancer. It's old, but it's the latest one from the CR UK, and you can see that childhood cancers are very, very rare. And obviously when you're a paediatrician they're pretty rare, but when you're a GP they're even rarer, because cancer always occurs in the older population. So we just need to be aware of that. I think we're often very accusatory of misdiagnoses of cancer in children and young adults, but they're notoriously rare. We can just move on. So the next slide, Abby, can you move on? Sorry. Abby, are you able to, sorry. So this slide shows how much, where cancer sits as a cause of death in sort of in 0 to 14-year-olds. So as I said already, in 0 to 14-year-olds, cancers make up less than 1% of all new cancer cases. There are about 2,000 cases per year, and the 5-year survival is very, very good. So there's only about, in the UK, 230 deaths from cancer per year. In 15 to 24-year-olds, again, they make up a very small percentage, and you can see this, the slide or the graphic on the right shows that actually for boys, cancer sort of is the 4th greatest cause of death, but in girls it's cancers make up 15%, but transport accidents, you know, are for boys particularly much higher, and for girls are coming close. Whoopsie, that is my sister, so I'll just end that, sorry. Comes, you know, cancer, but only just closely followed by those other causes of death. Okay, next slide, please. So what types of cancer do children and young people get? In the 0 to 14-year-olds, leukemia and brain and other CNS tumours are the commonest in boys, and lymphomas, and then in girls similarly, but many fewer with lymphoma. And the 15 to 24-year-olds, you'll be familiar with this. Again, lymphomas and carcinomas, particularly in girls, and then obviously the equivalent in boys are germ cell tumours. So those slides will be familiar to you. Unfortunately, I couldn't find more recent data than that. Okay, so this stuff you will all know, you will be learning it for your exams, but important to see where it fits. And what about the 5-year survival? So the 5-year survival is remarkably good in comparison to adults, and it's shown there. So this is 15 to 39-year-olds, and as I said, the average 5-year survival is over 80%. Next slide, please. There's been a huge raft of publications looking at the importance of end-of-life care in children and young people, and these are the key documents where it was really first outlined. So the end-of-life care, National End-of-Life Care Strategy, published by the Department of Health, published in 2008, and that was at the same time a commissioning framework for palliative and end-of-life care, which covers all diagnoses, was published in the same year as a framework for commissioners and providers. And the other documents are it's useful to be aware of. I'm sure you're not going to pore over them. Okay, next slide. The NICE quality standards for end-of-life care for infants and children was published in 2017, and there are 6 priorities. And I think these are very important to be thinking about. So this is for any young person with any life-threatening illness, that they should be involved in developing their advanced care plan with their parents where it's appropriate, and we'll come on to that. And there should be a named medical specialist who leads and coordinates their care. That they and their parents should be given information about emotional and psychological support, and that they should be cared for by a multidisciplinary team who are expert in the care of people in the last year of their life, and that their parents or the carers should be offered support. And in addition, anybody who might be in their last year of life being cared for at home should have 24/7 access to children's nursing care and specialist advice from a consultant in paediatric palliative care. I think those are great statements, but I'm just wondering, whether that's really available throughout the country. It used to be in the way that cancer care and palliative care had a relationship with patients, is that a child would have good health and they would have cancer treatment, and they would be coming towards the end of their life, and palliative care would be involved at the very end. So we would be seen as the Dr. Death sort of crew. And as you can imagine, that's remarkably difficult for patients and their loved ones. It's remarkably difficult for the oncologist who's handing over care, and it's also remarkably difficult for the palliative care team to be involved. So if you move on, I've drawn a sort of, that we no longer use that model of care. So if we can just move on, the next slide shows really how it should be. So the way I think that palliative care should be involved is that we are involved very early on from a child's diagnosis of a terminal illness. And we will often be involved with symptom control, with psychological support after a new diagnosis, to really talk to them about the sort of adjustment, to manage any pain that they may be developing, symptoms, nausea related to chemotherapy. And we have this sort of in and out model of being involved, and for patients who are cured, we may be involved right at the start and then actually never see them again because they're cured. And we're seen very much as a sort of symptom control, a supportive symptom control team at that point. And then you develop a relationship with that person. So should their disease progress and should the illness progress, and they're coming to the end of their lives, we are seen as people who are helpful and not just the death and dying group. So I would really recommend in any future job that you're involved with, that you try to develop that model of care with your palliative care colleagues. Okay, moving on. So early referral is best. I think it's really important to bust the myths of what it is and what it isn't. So what it is are experts in symptom control and psychological support who accompany anybody who has any life-threatening illness at any stage. So we are not the Dr. Death team. We do not only get involved with patients who are very close to the end of their life. So I think that's what we should be talking about. So it's about joint consultation, complementary roles with the paediatricians, with the oncologists, all that sort of symptom control, emotional support, and actually supporting for patient and their loved ones. And it's often the loved ones that we feel we find are missed out, particularly siblings, and we'll come on to that. And people who receive palliative palliative care late in their illness often say that they wish they'd had it earlier. And as I said, it's not about death and dying. 50% of people who are admitted to an adult hospice are discharged alive. Many people think that you only go into the hospice at the very end of your life, and that 90% of people are, die there. Actually, they're completely changed now. They're very much used to in and out of a patient's illness. Okay, next slide. So coming on to the sort of patient who has symptoms. So when the one thing that we do in great detail, and I suppose we are, as palliative care team, we're paid for, is to have time. So many generalists will refer and say, this patient's got pain, I'm going to put them on morphine. Well, what sort of pain is it? And really the way we use analgesics in palliative care is to really take a meticulous history. So we are looking at the trajectory of somebody's pain or any symptom or their nausea, how it starts. If we can just put on the next three, if you can move on, Abby. So how it starts, what do they think it's due to, what makes it worse, when they've got it, where is it, how bad is it, does it vary, what times of day, what associated symptoms are there, what effect does it have on their activities, what are they unable to do, and when it goes away, what makes it go away, do any of the medicines we have relieve it, all those sort of things. So you really get this sort of very clear picture. We can just do the next slide. The thing I think that people always forget, no, just go back one, please, is these last three on here. So many patients, young people with, say, a sarcoma or who've had a sort of a malignant diagnosis, they improve and then they recur, they get a recurrence. And usually, nearly always, people know it's a recurrence. So actually asking the question, so you're seeing somebody, you're thinking, oh man, here we have a metastasis. If you ask a child or a young person, what do you think is going on? What are you worried about? What do you think this might be? They will in many cases tell you, I think it's the cancer coming back. I think I'm more breathless because the disease in my lung has got worse. So actually, if you dare to ask those questions at the end of your assessment, so you take this meticulous standard medical story, and then you ask those three questions. What would you like? What do you think would be helpful? What are you frightened might happen? And those questions are really, really vital and often a gift in terms of getting there and understanding that they know their disease has come back. Next slide, please. I want to now talk about communication with a child or a young adult in terms of talking about a sort of giving bad news. Next slide, please. You can just move on, Abby. Okay, so I think we get so used to our environment, but actually hospitalization is alien, it's frightening. Cancer treatment is hugely intensive, and for a particular teenager, it's enormously invasive of your body, of your emotions, of your priorities, and of your independence. So teenage years is where you're beginning to separate from your parents, and suddenly you're incarcerated in a room with them for 6 months while you have treatment, which takes away all the things that make you you. And it can, and we see, and the data shows that patients with cancer, particularly young people with cancer, get aggressive treatment very close to the end of their life. And that's very, very difficult to manipulate and to manage, particularly when you're doing end-of-life care alongside anti-cancer treatment. Next slide, please. So studies have looked at, this is a very obvious slide, and I suppose it's what all of us want, whether we're living with a life-threatening illness or not. Actually, we want to be loved, we want to have choices, we need to be treated with honesty, we want a sense of peace, we want to be recognized for who we are, to have dignity, to be able to express our emotion in our own way, and to be communicated in a respectful way, and to continue to have goals and hopes. So when I'm looking after an elderly patient, you know, they're often talking about their normal life. For an elderly lady, their normal life might be seeing their grandchildren, chatting to their neighbours, making a cup of tea, watching their favourite soap, those sort of things. And that feels okay when you're dealing with the fact that you may be dying. You need to continue with some element of your normal life. What we find with children and young people is that their normal life is planning for their future. So often, even though a child may know that they're coming to the end of their life, they may well still start talking about their year off, taking their A-levels, taking their GCSEs in a way which feels as if I don't think they've understood, but actually that hopes and goals for a young person are those sort of things. So I think it's important not to be freaked when a child or young person is sort of planning for something which you think they know already is entirely unrealistic. Next slide, please. So the data on how children, what's going on when they're facing a life-threatening illness, whatever that might be, malignant or not, is this sense of uncertainty, this huge sense of fear. We know that particularly young teenagers are always very, very worried about their loved ones, and that they will very much have understood with a lot without explicit discussions. So I talk to a lot of parents about the fact that the child will have seen the hushed conversations, will have sensed the change in atmosphere in the room, and will have inferred things from that, some of which may be correct and some of which may not be correct. And actually, what's very important is a need to talk to a child or their loved one to try to to get to a point of their understanding of what's going on and how much they want to know. So what we often see is that a parent will be saying everything's fine, you know, there's nothing serious going on, and the child themselves will absolutely know that something very serious is going on. Most of us know when there's something serious going on in our world, and actually it's very important to explore and discuss and have a degree of honesty about what the child is feeling and what he or she senses is going on and what is being conveyed around her, so that they become congruent. We see that many parents try to avoid that. And why do they avoid that for all of this? Because they're they have these huge mixture of feelings of fear, of coping, of finding the right words. How are they going to talk to their child? They're frightened of actually what might happen, particularly in terms of the dying process, what that really means. There's this whole sense of guilt about whether they've put their child through too much treatment or not enough treatment. And actually, as a parent, your role, any of you who are parents, you know that actually your role is to care for your child, to look after them. You feed and you water them, you care for them, and then you're now in a situation when they have a life-threatening illness where you can no longer do that, and you can't prevent or control what's happening. And that is a huge sense of guilt, which often I think gets forgotten in the conversations with parents. I have experienced in some parents this sense of guilt that there's something they have done occasionally may have even caused their child's illness. You see huge tension between parents, tension between the patient and their siblings, tension between the parents and their child, and then huge tension, which you will all have experienced as a junior doctor with staff at times. And then they're furious, understanding, you know, the deal, deck of cards that they've been given is really tough. And I think having those 4 sets of ideas, because we deal with these very difficult parents, and actually we see them as difficult, we label them as difficult, and then we don't explore these 4 areas of what might be making them, you know, what the cause of that fury that you see. So really important to explore that. I'm always very worried about siblings. I think, particularly for patients in hospital for a long time, they have a huge mixed bag of feelings. They adore their loved one, their sibling. They sense a huge responsibility, huge desire to care, and also they are terrified. But yet they feel isolated and angry and jealous, and they resent the attention, they resent the change to their life, to their future that's happened because of their loved one's illness, and they feel second best and often then unloved. But actually they know that they can't express these feelings to their parents given the enormity of what's going on, and actually they deserve information and explanation. So I try to have those things in mind when I'm talking to them. So there's been quite a lot of, there are 2 slides now about the sort of way to engage in these tricky conversations and how to start them. The first thing is to make sure you're going to see a child or a young person and you have a sense of rapport and a sense of trust, you know them. So I've just been seeing a 23-year-old today who, I'm on my sort of second visit, and now we're able to joke and I'm beginning to start to explore her thoughts about dying, but it's taken some time to really develop her trust and make sure that I'm somebody who she respects. Clearly, honesty and empathy, and empathy is not sympathy. So empathy, being able to sort of understand begin to think about what that child might be going through. I think one of the phrases which I tell every doctor or medical student I ever meet not to use is, "I know how you feel." I don't think there's many more. I don't think any of us know how any of us feel at a time when we're going through something difficult. I usually say, "I can't imagine how this feels. This is just seems to me to be unbearable." So using those phrases rather than "I know how you feel" is really a helpful approach. Can you find words to express how you're feeling at the moment? Very important if we're talking to a family group is to understand and the dynamics and the key relationships. And so often with an adult, you have a relationship with the patient, but actually with a child, you have this triangular relationship with their parents or the key adult. And it's really important to understand how that is, how adult the 13-year-old or how childlike the 13-year-old is, or the 8-year-old. So you have some 8-year-olds who are really very independent and others who are very childlike. So you don't go by the age, you're really looking at the dynamics and the relationships and where the child is in terms of his or her relationship with her parents. And then you're also really important to understand how they communicate and what their culture is. So is there a culture of honesty and openness? Is there a culture of joking? Is there a culture of we don't express any emotions? Is there a culture of touch and feeling? What's going on before you, and you need to have a sense of that before you go in and start to deliver tricky news. And you come into your tricky news and you need to check out, what do they know? What sort of person are they? Are you somebody who likes to know a lot about your illness? Or are you somebody who likes just to leave it to mum and dad? Where are you? Where are you up to? What do you know about it? Do you have any questions? You have this enormous burden, this information that you want to convey, but you go to it really late. So you check out all of that, and you'll often find in many cases the patients will know what you want to tell them already, and really empower them to articulate their concerns and questions, reflect back, so that you say, okay, what I've understood is what we've discussed is this, this, and this. I've had a sense that you're feeling like this, and these are our next plans. So if you just push on, please, Abby. So this whole thing about ask, tell, and then ask. So ask where they're up to, tell them the news, and then ask further questions about about anything else, and make sure you sum up. Next slide. This is a very good guide, which I recommend. You can Google it. So it's all about very much saying the same sort of thing: set up the conversation, assess the understanding and preferences, share the bad news, and then explore by topic, goals, all these sort of things, and then summarize, make a recommendation, check in, and then make sure the next thing that will happen is this, this, and this, and then you do this, this, or this. So I'm going to come back later to see how your pain is. I'm going to come back later to see how you feel. So many times patients say to me, well, the doctor says she was coming back and she never has. That's that sort of thing, or he never has. It's important, just if you say you're going to do something, make sure you do it. Next slide, please. Decision making. So there's been quite a lot of discussion and guidance, which you, I'm sure, will be familiar with, about guidance, treatment and care towards the end of their life, and communication with 0 to 18-year-olds, and some stuff on CPR and CANAH, and that's very useful in with our sort of group of patients. And I recommend that you sort of look at those. I'm just conscious my battery is about to die, despite the fact that I've got my computer plugged in. Now I think it's working. Okay, next slide, please. So, guidance for all doctors in the care of 0 to 18-year-olds. You always need to act in the best interest of the child or the young person, and there are these challenges, and particularly if a competent young person refuses treatment, which is clearly in their medical interests, and particularly when there's a conflict between child protection and confidentiality. And it's really important you are seeking advice and using the named designated doctors for child protection and all those sort of things. So you'll be familiar with that. Next slide, please. Best interest. So you should be familiar with this, and I'm sure you would be sort of assessed on this in any sort of postgraduate exam, and you need to really seek out the views of the child or the young person when you're making a decision, reviews of the parents and anybody else close or important to the child or young person, to consider their cultural, religious beliefs. Think about the MDT. Often these conversations are tricky because there's a difference of view in terms of the sort of next step for somebody, and which choice, if there's more than one, will least restrict the child or the young person's future options. You should be familiar with that, but it's just important to remind you of those things. Next slide, please. Are you able to move on, Abby? I haven't got control. Okay, so much of this we've already covered in terms of a supportive partnership approach. I think that this whole conversation about CPR is always tricky. So actually, you don't offer somebody an appendicectomy if it's not something that's appropriate. So CPR is a treatment. You don't offer antibiotics which are inappropriate. You don't put that on the menu of your conversation. And CPR we have to think about as a treatment. So actually, if it is not going to restart the heart, it should not be attempted. If it may restart the heart, but there are potential benefits or harms, you need to consider the views of the child. And actually, if there is a difference of opinion, actually seeking legal advice is very important to do that early on. And actually, we need to do the most restrictive. So there's quite a lot of guidance about if there's a difference of opinion. So CPR is a medical decision. We see, in my view, what I see in pediatrics is often you will have very, very tricky conversations with parents and children about the lack of further treatment options and the need to take a palliative approach. And these conversations are hugely difficult, and CPR is not part of that conversation. And then suddenly there's another you go back to have the CPR conversation separately, and that somehow makes it more stressful and more difficult. So the way, in my experience, it works better is actually you talk about the fact that this is about dignity and quality of life, and making sure that we care for somebody as they deteriorate, and actually at that point that we do not artificially keep somebody alive. So these are tricky conversations to have. It really takes rapport and time, but important that we get right, and we don't do it as a sort of separate, isolated conversations. It seems to her still, despite all the guidance, be in a really sort of too difficult box, and then therefore my feeling is dealt with too late and in a somehow a sort of a cumbersome way. Okay, next slide, please. I don't know whether people are familiar with treatment escalation plans. So at UCLH, we have a treatment escalation plan which goes alongside a recommendation not to have CPR. And what that means is, so people often think is actually if you're not going to give CPR, then you're just going to give up. And a treatment escalation plan really gives clear guidance for emergency clinicians if a patient should deteriorate about what the person should receive. So they should have antibiotics. They may even go to ITU, and they should have organ support, potentially even, or ongoing chemotherapy, even if they're not going to have CPR. So actually, if you have a conversation around treatment escalation planning alongside CPR, it's often very, very helpful. So you're really saying, we are going to do this. So this is, you can see here, we even have, you may have, for consideration of critical care, yes or no, and these are the clinically indicated treatments, and these treatments are not considered to be clinically indicated, and then a DNACPR form alongside it. So having these two in tandem really make these conversations a lot more easy. Next slide, please, although I recognise that they are not, not so easy. I don't know whether people outside London, you're all in London, so outside London there is a process called the RESPECT, which is a recommended summary plan for emergency care and treatment. And in that really takes you through a conversation with a person, and now it's for children and young people, where you document the sort of priorities of the person and their loved one, and whether treatment should be aimed towards life-sustaining treatment or about comfort care, and then you articulate the sort of treatments that are clinically indicated, including whether hospital admission is appropriate. So that is something which, if you move out of London, is widely used. We don't use it in London because we have Coordinate My Care, which sort of guides clinicians in what to do in a child who becomes unwell in an emergency situation. So this is now for all ages throughout London. So any child who has a life-threatening illness, who is at risk of deterioration in the community, should have a Coordinate My Care record, and that is accessed by LAS NHS 111 if they are called to that address, and within it you as clinicians document, if this person deteriorates, this is what should happen. They should have CPR, they should not have CPR, they should be taken to hospital, this is their background diagnosis, these are the drugs that are in the patient's house. Currently there are almost 50,000 people in London with a Coordinate My Care record, which guides clinicians in what to do should they deteriorate. So I don't know if people are familiar with it. That's the disadvantage of not seeing anybody's faces, whether you're nodding or shaking your head, but I recommend you sort of exploring it. And Great Ormond Street, they create Coordinate My Care records for all the patients that they're caring for in the community. It requires consent, of course. So I'm just going to lastly talk before I stop about caring for a person in their last days or hours of life. Recognition is key, and I rest my case. I see sometimes that that's not recognised. Communication we've talked about, really finding out and seeing what the person and their loved ones want to know about it, and then looking at these key interventions. So looking at the CPR status, looking at hydration. It used to be that hydration and nutrition were discontinued when somebody was coming to the end of their life, but we very much are using an individualized approach when we're planning care, and that for many patients and their cultures, it would be appropriate to continue hydration and nutrition nutrition. It may have an effect on the length of somebody's life, but actually discontinuing can have a, and having an argy-bargy about it can be hugely negative to a patient and their loved ones. So we take a much more broad view than we used to. Reviewing the drug chart and discontinuing unnecessary medication, and making sure that the drug chart has medication to ensure that the person who is in the last hours or days of life has good symptom control. Next slide, please. This is quite an interesting study published by a Swedish group who sent a questionnaire to the parents of all children who died of malignant disease over a 5-year period. They got an 80% response rate, and they took down all sorts of sort of demographics, so sort of cultural experience of the family, whether they felt that the child was aware of their impending death, and whether they had had discussions, and whether, if they had or hadn't, whether they regretted having or not having discussions. Next slide, please. So interestingly, a third of parents had talked to their child about dying, and none had regretted it. 2/3 hadn't, and or just over a quarter regretted that they had not spoken to their child about it. But interestingly, the others, 73% did not regret it. The things that correlated with having a discussion and regretting not having a discussion were the sense, so if they was a sense whether the child was aware of their imminent death, whether their cultural beliefs, older children, parents regretted it more, socioeconomic status, the age of the parents, so older parents were often more able to have these conversations, and interestingly, the female parents regretted much more than the male parents. So the asterisk is, and often it was the female parents who had the conversation with their loved one about death. Just interesting study, and there hasn't been anything else more recent than that, interestingly. So, are you aware of the Association for Pediatric Palliative Medicine formulary? So that is the website, and that is hugely useful because for each of the drugs we use in palliative care, I use it all the time. It talks about the dose, and the dose depending on the patient's weight, for all the common drugs we use for symptom control. So I've just put that up there, whether it's for people carrying the last days of life or not. We will continue, of course, oral analgesics until a person is no longer able to swallow. Thereafter, we will use parenteral administration if a patient is in hospital. Often we'll use IV, but in the community we'll use subcutaneous routes of medication. And we sometimes have to consider other parenteral adjuvants, administration of adjuvants such as a non-steroidal or other adjuvant analgesics. If a patient is agitated, don't forget those distended bladder, pressure areas, and the need for turning there. Obviously, page 1, but they're often forgotten, and I've often been to patients who felt their bladder, you put a catheter in, and suddenly all the agitation and distress goes. Next slide, please. So if they're on an oral opioid, you need to convert to the subcutaneous infusion. So if a patient is on an oral opioid, such as morphine or oxycodone, to get the equivalent subcutaneous dose or intravenous dose, you divide the total 24-hour oral dose by 2. And then the PRN dose you prescribe is 1/6 of that 24-hour dose. If you are converting from fentanyl patch or converting to other opioids, so if a patient has renal failure, you will be using alfentanil or fentanyl, you need to seek advice from your palliative care team. You may need to continue diclofenac, paracetamol rectally, or ketorolac for musculoskeletal discomfort. If they're on a transdermal patch, we will often leave them in situ and then top up with a subcutaneous infusion. It just depends. Next slide, please. But this is where these are dangerous drugs. You do not need to be prescribing unless you are absolutely sure. And if you're not sure, you need to seek advice for obvious reasons. Restlessness and agitation is very common and very, very distressing, and it's really important to talk to families about that. Next slide, please. And the main, we obviously think about things that are potentially reversible. Think about metabolic changes, whether it's in any way relevant. Urinary retention, as I've already talked about. Next slide, please. And the drug we clearly most commonly use is midazolam, which is a benzodiazepine, and these are the doses that you would use. Second line, we will use levomepromazine. Levomepromazine in low doses is an antiemetic. At obviously at high dose is a sedative antipsychotic. It's a phenothiazine, but we again use it in very small doses as second line for terminal restlessness or agitation. We also use it, as you may well be familiar, in the management of nausea orally. Next slide, please. Secretions, we see that less in children and young adults, but really distressing. Often in a hospital setting, suctioning is used, but actually important to get drying agents in early, hyoscine hydrobromide or glycopyrronium, and the doses are there. Next slide, please. So I'm going to stop there. I've spoken for 40 minutes. It's really weird doing it when I can't see anybody's faces and see who's fallen asleep, and just see if there are any questions. Open it up, really. Abby, I don't know if you want to share that bit.
Yeah, hi. Thank you, Caroline. That was a really comprehensive overview. I'm not sure if you can see the chat as well. People tend to post comments there. So,
okay.
Someone has said, work at POSCU, and we recently had a couple of palliative patients be rushed. Sorry, can you see that, Caroline? Just because my screen is hard.
No, for some reason, screen. No, anyway, carry on. Just read them out.
Let me. So I work at POSCU, and we've recently had a couple of palliative patients be rushed in. One died en route in a parent's car. I knew luckily she was DNACPR, but I was acutely aware I didn't know her plan for end of life, and parents weren't in a place to discuss. We were in resus. Could I coordinate my care from there? As a department, we were considering a passport, as we have had a couple of cases like this, and I hate the thought that all their plans for end of life are not known and don't end up happening or aren't carried out. Do you have any advice for this?
So that sounds absolutely horrendous. So so what I would recommend is for you to explore Coordinate My Care. The difficulty is and to use that as where, so that is the platform that the LAS, the London Ambulance Service, will use. So I don't know if whoever's asking the question is living working in or outside London, but throughout London, we would be using Coordinate My Care. So if you have a relevant if you ask, so we are trying for all ED departments, emergency departments, to be able to access Coordinate My Care, and so for all acute trust to have federated logons. So because of information governance, the current situation is that in each healthcare professional needs an individual log for access to Coordinate My Care. Now, what we are doing is that actually just as you can see any patient record, using it within information governance rules, so you don't look up the CT scan result of your mate. We are trying to move Coordinate My Care so that it's available on all acute hospital systems, but at the moment it isn't. But if you are thinking about developing a passport, I would align it to Coordinate My Care so that the patient and their parents will be able to see it and will be able to, they could almost print it out, and that comes as the passport, but otherwise you're going to have two sets of information in terms of the fields that are completed. I'm happy for that person to email and we can take it offline, if that makes sense.
So yeah, thank you for that. They've just added that they were in London, but both children were brought in by parents, not LAS.
Okay, so I can now see the chat. Yeah. So I think, yeah, I mean, I think the thing here is, I think the key thing is, where were the conversations in terms of preparing those parents for that? Do you see, you know, and yeah, I mean, that would be my concern. And so you would some sort of passport along the lines of coordinate my care would be my recommendation. Yeah.
You mentioned that every child at Great Ormond Street is getting a coordinate my care record, but I presume in other hospitals it would be up to kind of the lead clinician to arrange that. And it's not.
Yes. So I know that at Evelina, they're also using it. So I think more, and the Marston down in Sutton, the paediatric palliative care team. So I mean, obviously, you know, they don't look after all the palliative patients, but they are really supporting the paediatricians throughout London to start to use that as the place to record this sort of thing. So that's the sort of I mean, that's been a move. There was quite a lot of resistance, but I think there's a real sense that actually it's really valuable.
Does anyone else have any questions for Caroline that they would like to either post in the chat or on mic themselves to ask?
Silence.
I had a quick question regarding kind of symptom control plans that you make in hospital, and kind of the frequency with which that's revisited. I've worked in oncology before, where when they're ward patients, that is revisited fairly frequently because they're seen frequently, but just how does that work in the community setting, and who does that with the parents and patients?
So the community paediatric palliative care team should be doing that. So how we do it when we're discharging patients from UCLH, we will make a symptom control plan for that child when they're going home, and then that would be reviewed. So in obviously at UCL, we're sort of a tertiary centre, so then the more local treating clinician would then review that. It's clearly going to be outside a GP's sphere of expertise. So then you would be very much sort of asking that local treating clinician to liaise with their palliative care consultant, and I think I have to say, in London, in my experience, it's quite different. So in some boroughs, the children's community nurses are all over this like a rash, and in others it's the community paediatric palliative care team, and it doesn't seem to me to be consistent. So you know, it should be reviewed, definitely. You know, I mean, it's tricky to say, and it depends. Obviously, when a child's condition changes either for the better or for the worse, it should be the care plan should be reviewed. But actually, you know, obviously during outpatients, just to make sure that if a patient is on a strong opioid and the doses increase, that the symptom control plan changes at the same time. So it's about empowering the parent, saying, look, this is almost your passport, you know, before the end of life care passport. Actually, we need to make sure that this is married up and updated, and how often is tricky to say, but, you know, not infrequently, I would say.
Thank you. Does anyone else have any comments or questions for Caroline before we close?
Super. You can go home and have a glass of wine a little bit earlier. Okay. I'm sure Abby will be sending the slides.
Thank you so much.
I do hope this is helpful. Okay.
Yeah, that was really, really helpful, Caroline. Thank you. It was a really comprehensive overview. The talk will also go up on the website shortly.